This lecture will examine the pathophysiology of aortic valve regurgitation, which is also referred to as aortic valve insufficiency. Normally the heart, the left ventricle, only fills with blood from the left atrium. But when we have aortic valve regurgitation, which means that blood is able to now flow backwards from the aorta across the valve and into the ventricle, we now have the ventricle filling from two different routes, from the normal left atrial route, but also from the aorta. And because blood is filling from two sources now, we'll find that the end diastolic volume, and hence the end diastolic pressure, is significantly increased. And because the end diastolic pressure is increased, that means that the left atrial pressure during diastole must also be greater in order to fill the left ventricle. And this volume overload condition will lead to left ventricular dilation and atrial dilation, and sometimes this left ventricular enlargement is referred to as eccentric hypertrophy, which means that yes, the wall is getting a little bit thicker, but it's getting thicker in proportion to the increase in its volume. Some of the blood that's ejected into the aorta is leaking back into the left ventricle. We therefore have a decrease in the net forward flow into the aorta from the left ventricle. And because we have blood leaving the aorta back into the ventricle, as well as blood moving down the aorta like it normally does, we will find that once the aortic pressure reaches its systolic pressure, it will fall very rapidly to a lower than normal diastolic pressure. In other words, the pulse pressure, which is shown here to be 100, is much greater than the pulse pressure here, which is 40 millimeters of mercury. And that's because, once again, blood is leaving the aorta from two different routes. To quantify the amount of regurgitation, one can calculate what is called a regurgitant fraction. Now, the regurgitant fraction in aortic insufficiency equals the volume of backwards flow across the aortic valve relative to the total stroke volume. If the total forward flow or stroke volume initially is 100 mLs, and it's enhanced because we have greater filling of the left ventricle in this condition, so it has a larger volume, and the Frank starting mechanism will operate, and it will therefore increase its stroke volume. So that's why I'm saying that the stroke volume might be 100 mLs instead of the typical 70 that I usually refer to as normal in my diagrams. So it's 100 mL, so that is the forward flow. But now during diastole, we may have 40 milliliters of that forward flow backwards into the ventricle. So the ratio of this value to the forward flow would be 0.4. So the regurgitant fraction, therefore, is 0.4 or 40%. Notice also that the backward flow is driven by the aortic pressure minus whatever the left ventricular pressure is. There has to be some pressure gradient driving this flow backwards into the ventricle. Once again, that will be the aortic pressure minus whatever the left ventricular pressure is as that flow is moving backward across that valve. Now let's see what happens to our pressures and volumes within the ventricle and the atria. During systole, we don't really see much difference. In other words, there's no real gradient necessarily across the aortic valve because it's a normal valve. But we will see a higher systolic pressure because there is an increase in stroke volume, because the ventricle has a large filled volume now because it's filling from two directions. So the stroke volume will be greater. So I'm showing an increase in systolic pressure for the left ventricle. But notice that once the aortic valve closes, that we have a more rapid runoff in the aortic pressure because blood is now, from this point on, starting to flow back into the ventricle and fill the ventricle. And so the diastolic pressure of the aorta will be reduced, and hence the difference between the systolic pressure and the diastolic pressure, or the pulse pressure within the aorta, will be greatly enhanced. Now, because of this backward flow of blood and increased filling of the ventricle, the ventricular filling pressures will be higher, and the left atrial pressures will be higher, as depicted here compared to some of our other normal graphs previously. For the type of murmur, we will find that the murmur will occur once the aortic valve is trying to close. It doesn't close completely because it's regurgitant, it's insufficient. And so at the time when the aortic valve should be closing, or at the S2 sound, you will find that this will be very quickly followed by a murmur that will reach a peak very early on, and then it will decline in intensity during diastole. So we speak of this as being a decrescendo type of murmur. The peak is reached when you have the peak pressure difference between the aorta and the left ventricle, because the pressure difference between this value and this value here is what is driving that backward flow. And so the higher the pressure gradient, the greater the backward flow, regurgitant flow, the higher the velocity of that regurgitant flow, and the greater the intensity of the murmur. As we begin to fill the ventricle further with blood and the aortic pressure falls, then the gradient for that regurgitant flow is reduced, and therefore the velocity of that regurgitant flow is reduced, and so the intensity of the murmur falls. Now let's depict this with a pressure volume loop. Dotted loop here represents our normal loop. But what we may see with aortic valve regurgitation is a greatly enlarged, dilated ventricle. In fact, this is a chronic condition generally, and so it will lead to a remodeling of the ventricle and increased compliance so it can handle this extra volume of blood. At this point here is where the ventricle would begin to contract. And so this would ordinarily be our maximal filled volume of the ventricle, but I want to point something out. If this is where the ventricle is beginning to contract and the mitral valve closes, you will not notice there being any vertical line. The ventricle is still filling with blood, because even when the mitral valve closes at this point right here, the pressure within the aorta is still greater than the pressure in the ventricle, and so blood is continuing to flow into the ventricle even after it starts to contract. Well, finally, the left ventricular pressure will exceed whatever the lower aortic diastolic pressure is, and now we will get ejection of blood. Now it's going to eject, as it ejects blood, it's going to generate higher than normal systolic pressures because the stroke volume is enhanced. And we have a more forceful contraction because of activation of the Frank-Starling mechanism. And then once the aortic valve quote unquote closes here, it doesn't close completely, and so instead of having a vertical line here or isovolumetric relaxation occurring, we find that once we reach this point here, the ventricle now immediately begins to fill with blood prior to the opening of the mitral valve, which would occur right about here. So this region from here up to here is regurgitant flow filling the ventricle prior to the mitral valve opening and starting to fill the ventricle. But once the mitral valve opens, it will then continue to fill the blood and fill the ventricle, and it's filling now with two sources, both from the atrium and from the aorta. So let's summarize these changes that are occurring with aortic valve regurgitation. Well, this condition is associated with, and this is a hallmark, so really put this, keep this fact in mind. you'll have a large aortic pulse pressure because you're going to have an elevated systolic pressure generally and a decrease in diastolic pressure. So the pulse pressure will be elevated. Now, you may not always see an increase in systolic pressure because with prolonged aortic regurgitation, the heart itself may go into systolic failure. And when it goes into systolic failure, it may not be able to generate that elevated systolic pressure in the aorta. But if it's not in systolic failure, if it's still able to compensate for this regurgitation, then the systolic pressure in the aorta will be elevated. There will be significant ventricular dilation because of eccentric hypertrophy, this remodeling that's occurring, and left atrial eccentric hypertrophy. You'll have a large increase in left ventricular stroke volume, the EDV minus the ESV, although the net forward flow into the aorta may be reduced. There will be a diastolic murmur, a decrescendal type. There will be no phase of isovolumetric relaxation or contraction. Because remember that isovolumetric relaxation and contraction only occurs because all four valves are closed and sealed. But in this case, the outflow tract valve does not close. So it's either open during systole or during diastole, it's partially open still, so blood can go back into the ventricle. And so there is no true isovolumetric phase. And we'll have left ventricular and diastolic pressure because of the volume overloading in the ventricle, and therefore an increase in left atrial and pulmonary capillary wedge pressure. And the large increase in stroke volume and the greater increase in pressure that the ventricle has to generate during systole will result in a significant increase in myocardial oxygen demand.